Appreciate the opportunity to be here today and welcome everyone to this live panel discussion on what is the best postnatal surgical intervention for posterior urethral valves. So when we talk about pediatric outlet obstruction, what we're not talking about is an enlarged prostate. What we're really talking about is posterior urethral valves. And this is something that we all have a strong interest in. Posterior urethral valves occur in basically two major types. And the majority of posterior urethral valves are essentially the type 1 posterior urethral valves, which are shown here in these different schemata. The other types of posterior urethral valves, which is more minor, is the diaphragmatic posterior urethral valves, which is the type 3 posterior urethral valves. And what we worry about when we have posterior urethral valves and lower urinary tract obstruction is the influence and impact it has on the detrusor smooth muscle. And that is with tension and stretch, we have shown in the lab that this results in two processes that is basically hypertrophy of the smooth muscle as well as hyperplasia. And this hyperplasia and hypertrophy is what results in alteration in bladder compliance. And it's this bladder compliance changes that are really what's so worrisome in these patients. These changes can result in hydronephrosis, reflux, as we've heard, renal damage, and ultimately renal failure. Our group at Texas Children's has looked at the renal outcomes in patients with posterior urethral valves. And this retrospective study in over 100 patients led by Dr. Abhishek Seth, we found that about 42% of our patients were diagnosed prenatally, and about a third of our patients underwent prenatal intervention. For those that underwent postnatal intervention, the majority of them underwent transurethral incision or endoscopic management of their posterior urethral valves. And in the 5% or minority of the patients, we performed cutaneous vesicostomies and diversions. About 42% of our patients required more than one surgery, and about 1/5 of our patients were labeled as chronic kidney disease, and more soberly, about 8.6% of our patients had end-stage renal disease. Now, the debate that has historically occurred in urology has been primarily with two distinguished pediatric urologists, Bernie Churchill arguing upper urinary tract diversion, and John Duckett arguing lower urinary tract diversion. And today we're going to have a new treatment debate with Dr. Jonathan Ellison and Dr. Bob DeFore. And Dr. Ellison is going to talk a little bit about the endoscopic management and ablation of valves, whereas Dr. DeFore will be taking on the diversion treatment with cutaneous vesicostomy. And I would like to now welcome Dr. Ellison to present his point of view.
Thank you for allowing me to sit on this panel. It's an honor to share the virtual stage with Drs. Austin and DeFore. As we were talking earlier, we had a Duke Med grad that's crashing these two UK basketball fans panel. So I'm going to talk about the endoscopic ablation for posterior urethral valves today. And on first glance, that might be look like an easy task. Dr. Austin had alluded to the fact that the vast majority of their series underwent endoscopic valve ablation. But there are plenty of nuances within posterior urethral valves that warrant further discussion. So the endoscopic valve ablation, in my mind, really provides the best shot to provide that bladder the chance to regain early function. And that's by eliminating the obstructive tissue and maintaining bladder integrity. By relieving the obstruction in a congenitally obstructed bladder, we can engage early bladder cycling and thereby show some remodeling of the bladder, thus improving upon the posterior urethral dilatation, resolving the vesicoureteral reflux, and improving upon the bladder trabeculation. And this has been reported for several decades now, actually. And it is fair to ask the question, now that we are in 2020, do studies that were published back in the 1990s and early aughts still apply? In other words, does our contemporary experience reflect a comparable population? So currently, we know that many of our patients are being found prenatally, and those patients do have a more severe disease process. They more commonly require vesicostomy. They may present with a higher nadir creatinine than those who present postnatally, and they have a greater proportion of upper tract changes in ultrasound. And in fact, in one contemporary series, in contrast to the Texas experience, up to 30% of children that were diagnosed early in life required urinary diversion from data that was accrued just within the last decade. And those that did were associated with worse renal outcomes, not because upper tract or urinary diversion results in worse renal outcomes, but because this is a more severe disease process that was selected for. We're now seeing an improved prenatal management, improved perinatal support, and peritoneal dialysis outcomes, which really result in a greater survivability of children with more severe disease, in fact, the most severe disease. And so in order to apply endoscopic valve ablation in this population, it's important to understand the principles upon which that treatment stands. So as Dr. Austin mentioned, the bladder develops quite abnormally under obstruction. We know in animal models, the bladder wall is hypertrophied with deposition of extracellular matrix and myofibroblasts. The human corollary to this also shows smooth muscle hypertrophy, as we're all very familiar with, but actually mostly an absence of collagen deposition, which may suggest opportunity for reversible change. It's also important to understand the histopathologic implications of fetal bladder diversion or chronic bladder diversion. So when the bladder cycles in a fetal animal model, the bladder develops normally. But once that bladder is shunted and diverted, bladder cycling is eliminated, that bladder actually develops abnormally. And if that occurs postnatally as well, that would be problematic and potentially argue against early diversion in these children. So I will argue that if we're able to do endoscopic valve ablation in a reliable and safe fashion, that it should be effective for the majority of our patients. Well, let's talk about reliability. This is a collection of studies published within the last decade or so with a focus on residual leaflets, essentially asking how well we did at relieving obstruction in these children. And overall, about 90% of children had their valves ablated with no residual leaflets after the first treatment. Now, the caveat here is that there is a wide variance in success rates between studies, between 1 and 60%, in fact. And so I would argue that even though endoscopic valve ablation is reliable, we should have a low threshold for repeat cystoscopy if the clinical scenario, follow-up imaging, or follow-up renal function suggests that we are not getting the outcomes that we would prefer. Endoscopic valve ablation can also be safe, but the correct technique must be applied. This is a nice study comparing techniques for endoscopic valve ablation between diathermy or cautery and cold knife ablation. And this group reported that persistent obstruction was significantly more common in the diathermy group as compared to the cold knife group, which was substantially driven by the rate of urethral strictures. So if we're going to apply endoscopic valve ablation, we need to apply it in the safest way possible, and this data would suggest that that would be cold knife ablation. But if we're able to support this in a safe and reliable fashion, then endoscopic ablation is effective at reducing future morbidity and potentially improving bladder outcomes in patients. The Philadelphia experience from the mid-90s showed this quite nicely, in which of the patients who were ablated, there was a very low rate of repeat open operations. It should be noted that in this series, 74 patients were ablated as compared to only 13 with a vesicostomy. So even with a selection bias, the majority of patients did well. And only 4 of those patients that were ablated were converted to early to vesicostomy. Now, there's very few studies that compare actual bladder outcomes between urinary diversion and endoscopic valve ablation. But we do know that endoscopic valve ablation provides very reasonable bladder outcomes for these children. I usually tell families never to expect their child to have a normal bladder, but still, 80% or greater will have resolution of their vesicoureteral reflux and incontinence, and only a third will have poor compliance, overactivity, or hypocontractility. When we look closer at the bladder outcomes, we can see that an early intervention is quite important. So those children with the earliest intervention within that neonatal period across the board were reported to have more favorable bladder outcomes than those followed with more delayed intervention, significantly so for hypocompliance and instability. And this would argue that potentially there is a golden window of time within the infancy that it's important to resume a physiologic bladder function. But what about the upper tracts? This is data that I've reworked from the Toronto group's experience and Dr. Farhat's paper from 2000 into a figure form for the talk. But they essentially looked at the outcomes of hydronephrosis and vesicoureteral reflux following valve ablation or diversion. They saw a substantial amount of downgrading of hydronephrosis with a fair degree of resolution following ablation, with a modest amount of downgrading following diversion and very little resolution. Similarly, downgrading and resolution were seen for vesicoureteral reflux following ablation, but really no change following diversion. So we make these kidneys look better on imaging and can improve upon the hydronephrosis and vesicoureteral reflux. Soberingly, however, it is very challenging to mediate the end-stage renal disease outcome. So the Philadelphia experience from the mid-90s showed that there is really no difference between upper and lower tract diversion and endoscopic ablation in the ultimate outcome of end-stage renal disease. Looking at this in a more contemporary cohort, Chua et al. From Toronto showed that actually for those children that had already progressed to chronic kidney disease stage 3, the combination of valve ablation plus vesicostomy did delay the time to end-stage renal disease, but the ultimate proportion of children who reached end-stage renal disease was really no different between these two groups. So while this may suggest that at some point in time there is an appropriate chance to apply vesicostomy, all of those children were still ablated early in life. And it's very hard to predict when you're seeing that child in the NICU, which of those children are going to progress on to end-stage renal disease and which of those children are going to settle out at something a little bit more reasonable. So does endoscopic valve ablation still apply? Well, certainly we're seeing a more severe disease with potentially a higher risk of early bladder failure, but those children are challenging to predict while you're making these early treatment decisions in the NICU. So I would posit that if you take on endoscopic ablation with close follow-up and a low threshold to evaluate the urethra, early valve ablation still remains the best shot at normalizing the anatomy and returning the bladder to physiologic voiding early. And as my two colleagues, both Kentucky Wildcat fans, know, that shot is quite important. Thank you. I will now turn it over to Dr. DeFore.
Thank you, Jonathan. Hard to follow up on that last comment there. So my task in this debate is to discuss the role of urinary diversion in neonatal bladder outlet obstruction. I'd like to thank Dr. Austin, Dr. Braga, and Dr. Ellison for allowing me to participate in this talk. So I'd like to start with a case presentation. This is a baby born at 32 weeks, had a prenatally diagnosed bladder outlet obstruction with anhydramnios, had a shunt placement at 20 weeks, and then had a rupture of membranes after amnio infusions. Was only weighed 1.3 kilograms and had pulmonary hyperplasia, chest tubes, was pretty sick. Had a solitary dysplastic left kidney, and as you can see on the top right, and on the bottom right, the bladder was distended with a shunt in place, but likely somewhat malpositioned. We were unable to pass a catheter at the bedside, and so the baby was taken to the operating room on day of life 2, which showed urethral atresia. A vesicostomy was performed, and a thick-walled bladder with polyps that was severely inflamed was found, and we removed the shunt. The creatinine continued to rise, as you can see from the top left, up to a peak of about 7. The serum sodium dropped. The baby became anuric, fluid overloaded, was quite sick, and only weighed 1,600 grams. And our limit or our threshold is 1,800 to perform peritoneal dialysis. An ultrasound at that time showed an echogenic kidney with a massively dilated hydroureter. So we underwent a ureterostomy basically as a bridge to dialysis. And as you can see, the creatinine dropped and came down to a nadir of 1.9. We started peritoneal dialysis 5 months later at a weight of 4.1 kilograms. So as Dr. Austin and Dr. Ellison have already discussed, valves as our topic today. This occurs in 1 to 3,000 to 1 to 8,000 live births. About half of the boys are at risk for chronic renal insufficiency. A nadir creatinine over 1 is a poor prognostic sign for renal reserve. About 15% of renal transplants in children are due to some sort of obstructive uropathy, but about half of those have a structural abnormality in those under age 1. So we've had a lot of advances in valve management over the years. There's been a decreased mortality down to about 5%, according to a recent FIS data review. This is likely due to a lot of NICU supportive care, ventilatory, nutrition, nephrology care. End-stage renal disease management, like I said before, peritoneal dialysis can be offered at 1,800 grams and then transplant at some point after 10 kilograms when ready. Instrumentation, as Dr. Ellison talked about, has improved, and primary valve ablation is often feasible in even small infants. We use a 9 French infant resectoscope with a hook electrode, as you can see here. In the fetal care center era, a multidisciplinary approach is undertaken to confirm the diagnosis with serial ultrasounds and a fetal MRI. Extensive prenatal counseling is usually the rule to let the families know that this is a challenging journey. There's often renal insufficiency, particularly in the fetal care center sort of survivors, and that lifelong bladder management is the rule. We optimize pulmonary function prenatally with amnio infusions and an amnio port at sometimes. And prenatally, there's sometimes intervention with severe oligohydramnios when there's felt to be some preserved renal function. Our goals after birth is immediate bladder drainage and then primary valve ablation, as Dr. Ellison discussed, when stable, supportive NICU care, close monitoring of the upper tracts and renal function, and have nephrology early on to consult on the case. We try to minimize infections and sepsis. So after your transurethral resection, if feasible, bladder function is certainly important. Like Dr. Ellison mentioned, bladder cycling. Sometimes we add anticholinergic medication or clean intermittent catheterization to kind of rehab the bladder. Renal function, however, is more important. And so in the worst cases, then you sometimes will have to do a urinary tract diversion. So early CIC is a hallmark in our program for most of these severe cases, and the indications would be worsening renal function after valve ablation, worsening high-grade hydroureter nephrosis, a markedly abnormal bladder appearance with or without dilating reflux. So on to a vesicostomy, which is sort of my primary goal in this talk. When would you choose a vesicostomy over a primary valve ablation? Well, perhaps when an infant is too small to safely allow passage of the resectoscope, perhaps in urethral atresia, like the case I presented before, or in the case after a primary valve ablation has been performed successfully and you feel CIC is indicated, but is unable to be performed either due to some urethral anomaly or a family social concern, or just unable to have it done. When would you consider ureterostomy or higher upper tract diversion? Typically, this is the case in the worst cases when you have a catheter in the bladder that's draining nicely, the bladder is decompressed, but you still have progressive worsening hydronephrosis despite adequate bladder drainage. And this is usually due to secondary UVJ obstruction due to tortuous ureters and a thickened bladder wall. And you want to optimize the renal function with just very low pressure drainage. You can consider nephrostomy, as you can see in this case here, but at some point they'll need a more definitive diversion if the UVJ obstruction does not improve. This is another case. This is a fetal MRI of a baby that was diagnosed with bladder outlet obstruction with anhydramnios that initially oligohydramnios, but progressed to anhydramnios. They were delivered at 36 weeks with bilateral hydroureter nephrosis, as you can see here, and a very thick-walled, albeit decompressed bladder after the catheter was placed. So the creatinine continued to rise in this child, and so we performed bilateral percutaneous nephrostomies when the creatinine reached 2.7. The creatinine dropped quite nicely, and at some point, we felt like this needed to be converted to ureterostomies. And you can see currently, several months later, the creatinine is down to 0.4. 3 months post-op, the baby has 2 well-draining, low-end cutaneous ureterostomies via a fan and steel incision. The kidneys are almost completely decompressed, and like I said, the renal function is normal. So there are some concerns with upper tract diversion. There's really no long-term preservation of renal function that's been documented in most of the contemporary studies. Bagley and colleagues showed that it could delay time to dialysis. According to our nephrologists, it does help preserve renal excretory function, and it's nice to have some urine. Some urine is better than no urine, particularly if the baby were to require some sort of major abdominal surgery and you wanted to let them sort of limp along for a couple of days without converting PD over to HD. And it does require a lower percent dextrose in the dialysate. Unfortunately, it does require additional major surgery for either ureteral reimplantation or undiversion with a ureterostomy if an upper tract high ureterostomy is selected. And then as Dr. Ellison mentioned, there's concern for defunctionalization of the bladder and loss of bladder cycling. Unfortunately, the studies that we have are hampered by a lot of selection bias, as of course, the diversion is reserved for the most severe cases, and there's no prospective studies. And additionally, there is a challenge of comparing urodynamic data in cohorts of patients that we know have evolving bladder dynamics as they age through the sort of the changes of the valve bladder. And there's been some conflicting data. The sober ureterostomy may be less deleterious, according to a couple series. Dr. Glassberg felt like a vesicostomy could actually rest the bladder. And then sort of 2 of the more recent studies I could find from Podesta showed that there was better bladder function after a TUR rather than a primary vesicostomy. Just to show you how rare these procedures are, in our fetal care center, we did 380 bladder outlet obstruction consults in the last 15 years. And in our active PUV registry, we have 424 patients. And of those patients, only 10 renal units were diverted. So about 2% of patients underwent proximal ureterostomy. Of those patients, about the mean creatinine was around 4 at the time of diversion and then decreased to about 2. Over half ultimately required PD with a latency of 1 to 5 months. One patient is still kicking along with a creatinine of 1.3 11 years later. So in conclusion, cutaneous vesicostomy is an option when primary valve ablation is not feasible or subsequent CIC after successful TUR cannot be performed. A cutaneous ureterostomy is rarely needed. It may stabilize renal function and serve as a bridge to dialysis in the most severely affected patients. The ultimate bladder function effects are somewhat unclear after diversion. However, most valve patients will need some active bladder management regardless of the initial treatment. And in our hands, aggressive early CIC and anticholinergics has been the hallmark and may limit progression of the valve bladder to an atonic bladder. And that's everything I have. So back to you, Dr. Austin. I think you're muted, Paul.
Can you hear me now?
Yes.
Perfect. Well, thank you guys very much for excellent talks. And we have about 10 minutes to go here. And we have several questions I'm very excited to see. One of the things that I wanted to bring up, and this is one of the questions, was you alluded to this, Bob and Jonathan, you presented the endoscopic approach, but when you say an infant is too small to allow safe passive scope, what is too small? Is that 3 kilos? Can you elaborate a little bit more on that patient selection?
Sure. So, like I said, our smallest infant resectoscope is 9 French. You could try a laser ablation with a smaller scope, like a 7 French, or even our 4.9 pediatric cystoscope. I find that sort of a frustrating approach with the laser. So if I can't really easily pass the 9 French infant resectoscope, then I might consider diverting.
Dr. Ellison?
Yeah, I don't have a size cutoff. What we've done occasionally, if the infant or neonate has had to be stabilized in the NICU, we've actually changed the catheter out and tried to upsize the catheter and get a little bit of soft dilatation prior to going to the operating room. And if there's a concern that it might be too tight, I'll usually prep the families that if I can't get the scope in to do the ablation, I will do the vesicostomy at that time, so that they're prepared. So,
thank you. There's a couple of questions about the bladder neck, in particular, an old procedure, a bladder neck incision, and I remember doing this when I was a resident, particularly for men with BPH. I'd like to hear your all's thoughts about any particular role with bladder neck incision. I know for me personally, I've had some experience and success using alpha blockers to handle bladder neck dysfunction if that is an issue. But do you guys ever consider bladder neck incision for patients with bladder neck dysfunction with post-urethral valves?
That's a great question, Paul. I actually have not ever attempted to do that. I've heard of that and read about it. But like you said, I tend to try to, if I have urodynamic data, maybe in an older child that's voiding, that has primary bladder neck dysfunction, then I'll definitely be aggressive with alpha blockers or maybe even CIC if I see progressive dilatation in the upper tracts. And some, like I just saw a child that's 8 that I'm now finally deciding to pull the trigger on CIC, and I've been reticent for many years. And we've tried alpha blockers and we've tried timed voiding and biofeedback, but I've never actually gone back into incised bladder neck.
John, how about yourself? Yeah, I personally don't have experience with that either. I do know there are some studies that have supported that in a select population. I've also used medication and alpha blockers if we feel that the bladder outlet needs to be addressed. One thing I think that posterior urethral valves would really be ideal for is some sort of prospective multi-institutional data capture, much in the same way that spina bifida has been standardized, so that we could actually understand what parameters maybe we should be looking for in terms of some of these modifications and treatment.
Well, one of the questions that we received was, and this is kind of a good practical question, that is it ever needed, or do you guys feel the need to check the urethra for residual valves after endoscopic ablation? And if so, what makes you more inclined to do so? Jonathan?
Yeah. Oh, sure. I can start out, I guess, because I mentioned that in my talk. But so I will be honest with you that preparing this talk kind of made me rethink my practice. My practice is typically to get repeat VCUGs and then look inside again if there is a concern, either based on the appearance of the bladder or posterior urethra on the repeat VCUG, or persistent hydro, or a rise in creatinine over time. But I will say that in that slide that I put up, the series that reported the 50 to 60% recurrence rate or residual leaflet rate were all series that looked in every patient. And so I think that it's something that I've been reconsidering. Maybe that's something that is important. We have to weigh that against the risks of anesthesia. I think currently right now, I'm still sticking with my practice of VCUG and indications, as I've already mentioned, but I think it's something that is, I'm batting back and forth in my head about what the right answer is there.
Thank you. Bob?
Yeah, so that's a great question. I actually have not made that part of my practice to go back routinely to do a cystoscopy if the follow-up VCUG shows that the posterior urethra is open. If there was a situation where there was still concern that there was sort of a change in caliber of the posterior urethra and the radiologist concerned that there might be residual leaflets, that might be a situation that I might go back in and do another look. But I can't think that I've had to do that too often. For the most part, not a routine practice.
So we've talked a little bit and mostly about postnatal interventions. What do you guys think about prenatal interventions? Bob, I know you guys have a fairly aggressive fetal care center as we do at Texas Children's. What is your thought about the role of prenatal intervention for these patients?
Thanks, Paul. So again, if you go back to the slide I showed, it's overall pretty rare, but we've done some fetal valve ablations, endoscopic valve ablations. We have not done any fetal open vesicostomies in a while, but they're very aggressive with amnioinfusion, amnioports, replacing the amniotic fluid to create sort of a pulmonary survivor. But again, overall, fairly rare situation.
So, go ahead, John.
I was going to say, we don't have experience with fetal intervention as compared to vesicostomy or ablation, but very involved in the counseling. And I think that really, across the board is key, is just that counseling as we're seeing more and more severe patient presentations who are getting the amnio infusions and, aggressive shunting, maybe multiple shunts throughout their course, is to make sure that the families are prepared for what the bladder and renal outcomes are going to be postnatally.
There was a couple of questions about the bladder function and bladder recovery. For instance, when do you guys implement the use of anticholinergics for these patients? Another question along the same lines was, let's say you do a vesicostomy, allow the bladder to cycle. Do you see with this cycling and then closure of the vesicostomy that it has indeed had a good impact on the bladder and it does seem to be functioning better?
I wouldn't say I have a whole lot of data on how the bladder recovers after vesicostomy. I will say that in the very worst cases, that most of those patients will end up being on CIC and anticholinergics, and that we have transplanted into a bladder that is diverted to a vesicostomy. It's not ideal by any means, but they're too young for a Mitrofanoff, and they just have to have a safe drainage for the allograft.
What about anticholinergics? Do you guys use anticholinergics, Jonathan?
Yeah, we will. I typically will go if we're concerned about how the bladder is looking and the upper tracts are looking early in life, then I'll typically do urodynamics, not as a matter of routine, but in an infant, but certainly if indicated, and could use some of that data to start an anticholinergic. I could, and also if you feel like urodynamics are indicated, but for whatever reason you can't get a urodynamic catheter or a good study in an infant, then you may start anticholinergics empirically with progression of the upper tract hydronephrosis or worsening renal function. And I think to Bob's point as well, just the institution early of CIC or those children that ultimately get converted to vesicostomy may also help. It's part of the bladder drainage piece too.
Well, thank you very much. I think we're about really reaching our limit here of our session. There will be a 10-minute break for everyone. So get your coffee or water or take a bathroom break, depending on your need at this time. But we will rejoin back in about 10 minutes. So thank you guys. And thank you, everyone. Bye-bye.